chair the session today and handle the Q&A at the end. Hi, Tilly.
Great, thanks, Sarah. Good morning, everybody. As Sarah said, my name is Tilly Payne. I'm on the executive of the association, and my role on the association is to support the early career health service researchers. I'd also like to encourage you to join and echo what Sarah said about joining. It's not an expensive professional association, but there are some great benefits to being in the association. So today it's my pleasure to introduce Professor Andrew Georgiou. Professor Georgiou leads the Diagnostic Informatics Research Team at the Australian Institute of Health Innovation at Macquarie University. So he's worked in a number of senior research and executive positions both in the UK and in Australia. He's the editorial board member for 2 informatics journals. He's the co-chair of an International Medical Informatics Association working group on technology assessment and quality development. He is a fellow of several professional colleges, for example, the Australasian Informatics and Health Service Managers Colleges, and he's a foundation fellow of the Australasian Institute of Digital Health. His research interests are in the areas of diagnostic informatics, evaluation, health information technologies, outcome measurement, quality and safety, aged care, and organisational communications research. So welcome, Andrew. And he'll present his work today on evaluating the appropriateness and quality use of pathology in Australia, which I'm really looking forward to. Thank you.
Thanks very much, and thanks for that introduction. So I might start off by acknowledging my team, the Diagnostic Informatics team at the Australian Institute of Health Innovation, in particular Dr. Rayanne Hardy, Dr. Chrissy May, Guy Safi Franco and Gorkum Seskin, who contributed to the preparation of this presentation and the work that we've done evaluating the appropriateness and quality use of pathology in Australian general practice. What I'm going to do is firstly give you an overview of the role and the importance of diagnostic informatics, probably try and define it a bit for you. I'd like to talk a bit about general practice and electronic health record data. I think it's an area that's going to be expanding in the next period. There's a lot of developments going on recently, particularly in relation to the response to COVID-19. I'll talk to you about 3 areas where this presentation is going to concentrate on, and that's where we've looked at the quality use of pathology and patient care outcomes. They're going to be quality care for diabetes 2 patients, PSA testing, prostate-specific antigen testing in general practice, and vitamin D testing in general practice. And I'll end up with a little bit of an overview of the challenges of using electronic health record data, and obviously some of the advantages of doing so. So this is a model that's from the Committee on Diagnostic Error in Healthcare. It's from the Institute of Medicine in the US. Came out in 2015. I think it encapsulates a lot of what I feel is important about in health informatics and digital health and communication. So it starts off with the patient who might engage with the healthcare system. And you can see from the moment they engage with the healthcare system, there's a sort of a spiral or an iterative process where information is gathered, it's integrated, it's interpreted, there's a working diagnosis, there's clinical history interviews, there's examinations, there's diagnostic testing, and there's referral. So that information is being constantly gathered, and then as a result of that, it's communicated. So where an explanation of the health problem is communicated to the patient, and then it might sort of come back again. Maybe there's some changes to the health condition. So in my view, that sort of information integration and communication are critical to the informatics, to the patient care process. So diagnostic informatics therefore becomes a key component of patient care. So diagnostic testing, for instance, whether it be lab medicine, anatomic pathology or medical imaging, it actually generates information that's very crucial to the prevention, diagnosis, prognosis, and treatment of disease. I define diagnostic informatics as the role that information technology plays in helping to generate information, gather, integrate it, communicate it, not just as data, but also as information. And the sorts of things that this involves is the selection of the appropriate test or the referral to address a clinical question, the quality and efficiency of the analytical process, interpretation and communication and follow-up of test results, including engagement with patients, and also the impact on enhancing the value of care and patient outcomes. So just to sort of emphasize how important this is, every year the Emergency Care Research Institute in the US comes out with its top 10 patient safety concerns. And every year there is one concern that sort of features prominently, and it's always related to something about test result management. In 2019, the top of the list of patient safety concerns was diagnostic stewardship and test result management using electronic health records. So general practice, we've chosen general practice because it's an area that hasn't been studied as widely in the context of pathology testing as I think should have been. The reason it's important, obviously, is because it accounts for 70% of public funded pathology services. And although there's significant implications of pathology testing on the diagnosis of patients and their outcomes, there is a limited availability of high quality and reliable data about testing patterns. Historically, it's not been available, and it's been difficult to assess the utilization of pathology tests. But more recently, the Medicare Benefits Review, as part of a major initiative, has actually identified key clinical areas where the use of diagnostic services could be improved to provide better practice. It's in the context of a lot of initiatives, such as Choosing Wisely, which is seeking to reduce the inappropriate use of tests, treatments and procedures, and as part of a collaborative effort worldwide, which involves specialist colleges, societies, health professionals, and consumers. The types of issues that the MBS review targeted in there recently were things like iron studies, where they've been used for investigation of iron deficiency, but perhaps concern that they've been misunderstood or used unnecessarily or been misleading. You would have heard of vitamin D is one of the areas that they've targeted, perhaps ordered too frequently and costing a lot of money, repeat testing that might be unnecessary. So there's a number of areas where pathology testing in general practice has come under the spotlight. And as a consequence of that, we felt that there was a project that needed to be aimed specifically at general practice. So what we aimed to do was define the characteristics and changes over time in patient, general practice and pathology interactions and services. And we wanted to identify some key areas to monitor compliance with evidence-based guidelines, particularly relating to the appropriate and quality use of pathology in general practice, and identify and measure variability using a number of statistical process control methods. The project involved a series of collaborators, starting off with Centre for Health Systems and Safety Research at the Australian Institute of Health Innovation, where I work, Macquarie University. Outcome Health, which is an organisation that's actually managed to sort of put together a lot of electronic general practice data. The Gippsland Primary Health Network, the Eastern Melbourne Primary Health Network, and the Southeastern Melbourne Primary Health Network, which all collaborated with us, along with the Royal College of Pathologists of Australasia Quality Assurance Program. The project was funded by the Australian Government Department of Health Quality Use of Pathology Program. This is a program whose goal is to achieve improvement in health and economic outcomes from the quality use of pathology through the pursuit of better practice amongst requesters and referrers and providers of pathology services, and also engaging with consumers. The study was undertaken using data from the three PHNs, Gippsland, Eastern Melbourne and Southeastern Melbourne, across Victoria. It covered metropolitan and rural areas. Probably over 3 million people, probably covers about 30 to 40% of Victoria. Outcome Health is a data custodian. It has its population level analysis and reporting POLAR tool, which usually routinely gathers de-identified and secured electronic patient data from various clinical information systems. And we received ethics for this project was undertaken from POLAR, from the Royal Australian College of General Practitioners, and also from Macquarie University. Some of the background to the data analysis was that we had to actually identify what an active patient is. Because in Australia, as you know, people can go to different GPs. So we defined active patient as per the Royal Australian College of General Practitioner guideline, a patient who has attended the practice 3 or more times in the past 2 years at the time of visit. The population that we used was the ABS 2018 for standardisation. Regional socioeconomic status and geographic rurality of patients' residents were identifiable by linking postcodes in the demographic data set and the public census data. And also we used the index of relative socioeconomic advantage and disadvantage to assess socioeconomic index. Remoteness of patients' residence was also located, mapped from the Australian Statistical Geography standard from the Australian Bureau of Statistics. So taking that all into account, this is the number of active patients that we were able to look at over the period 2008-9 to 2017-18. Active patients accounted for approximately 60 to 65% of all the patients in from that period, 2008 to 2018. The proportions of active patients were relatively consistent for the last several years, and that's probably because the sample increased over a period of time as the POLAR data collection improved or received greater numbers. PHN had the largest number of active patients, that was over 354,000 in 2017, and PHN3 was the second largest. PHN2 is situated in a regional area with a smaller population and a smaller active patient grouping. Until recently, data about general practitioners was mostly gathered from the Bettering the Evaluation and Care of Health study, BEACH study. It was based at Sydney University. And this was the most comprehensive data we were able to obtain about Australian GP activity. It was a survey and was and when it discontinued in 2016, it left a big gap in our understanding of GP activity, particularly in relation to pathology test ordering. In the recent period, the extensive use of computers by Australian general practitioners has prompted interest in the use of electronic health record data as a resource for monitoring the quality of GP services, and that's led to research and publications based on these data. So what this figure shows is a comparison of patients' age and gender distributions between our data, the extracted data on the bottom, and also the BEACH data, excuse me, from 2015-16. So the BEACH data wasn't standardized, but there's a similarity in the overall pattern of patient distributions, which suggests that there's comparability between the two data sources. The 10 most common reasons for a GP visit in the period 2017-18. Well, we've given 3 groups there. For the infants, immunisation, viral upper respiratory tract infection were the top. When you move over the 25 to 44 years, young adults getting on, you can see that the visits are related to discuss results, a care review, prescription, immunisation. And older people, there's a lot more care reviews, prescriptions, and health assessments. So it gives a sort of a snapshot of different age groups and why they're visiting their GP. The frequency of pathology testing. Well, the median number of total pathology requests was around 20 requests per 100 visits. there were more pathology requests for older patients, slightly more pathology requests for female patients than male patients, more pathology requests for the advantaged, socioeconomically advantaged groups than the less advantaged, and more pathology requests were ordered for patients who resided in regional areas, more so than in the city areas. So we've got some data. We've got an overview of general practice data. We've got an overview of pathology. So let's look at it in terms of how it impacts and how we can measure the quality of care. The first one to look at is HbA1c, monitoring for patients with type 2 diabetes. In Australia, guidelines recommend that HbA1c testing for patients with type 2 diabetes occur every 6 months if one's blood glucose level is within the target range. That's less than 53. So if it's 53 millimoles per mole, within the range of 48 to 58. If the HbA1c level is outside of the reference interval, monitoring is recommended to occur within 3 months. So from our data, we were able to see that some 65% of type 2 patients, that's on the left-hand side, looking at that on the screen, overall 65% of type 2 diabetes patients had testing 2+ times on average. But there was 21% that had no HbA1c test performed. Australian guidelines, general practice guidelines, recommend an annual kidney function test for type 2 diabetes patients. This is because of the high risk of kidney disease. Pathology tests that indicate kidney function are albumin-creatinine ratio, ACR, or the estimation of glomerular filtration rate, EGFR. Annual kidney function tests are also part of a practice level service incentive payment paid to GPs to enhance the provision of quality care in general practice. So this is a funnel plot for monitoring practice performance. And so it gives you an idea of the practices that are performing well or are monitoring better than others, the proportion of patients who had annual kidney function tests. It also gives you a sense of what different sizes, how small practices might compare to medium practices and large practices, and also those outliers that might be cause for concern, or maybe that you need some sort of investigation to see if there's some problems with accessing patients or carrying out the tests. Service incentive patients. So this is a look at comparison of the proportion of patients with and without the service incentive payment by the time it takes to have the kidney function test. So if you evaluate the potential effects of an incentive program on annual kidney function testing, accumulated pot is a nice way of going about it. So you can see that the group of patients within the incentive program had a higher proportion of that completed the annual test when compared to those that didn't have that incentive, were not part of that incentive payment program. Based on the results of the kidney function test, we were able to identify nearly 7,000 patients who had abnormal levels of ACR and were suspected of having microalbuminuria or macroalbuminuria. Among the patients with suspected albuminuria, 76% had prescriptions for ACI, or angiotensin converting enzyme inhibitor, or angiotensin II receptor blocker medications during the study period. So we're able then to sort of say, okay, so if they've got either of these conditions, are they on medications? Have they been recognised based on the test results? So overall, 77% of patients with suspected, those two suspected conditions had prescriptions of their antihypertensive medications. So the next one I'll talk about is prostate-specific antigen testing. So prostate cancer is the second most common cause of cancer death in Australian men. There is evidence that indicates that there is inappropriate utilisation of PSA testing. The MBS Review Task Force that I mentioned earlier recommends that testing align itself with the guidelines from the Prostate Cancer Foundation of Australia and the Cancer Council of Australia. And these guidelines recommend that there should be a PSA test every 2 years for those in the age range of 50 to 69. A repeat test, as well as the measure of free to total PSA percentage within 1 to 3 months for those with initial PSA higher than 3 micrograms per litre. And prostate biopsy for those with repeat PSA greater than 5.5. So having a look at the data on this, it's interesting to see that in the total area, some 45% of men were in the bracket age 50 to 69, and then there was a significant proportion, 40%, that were over 70. So we can look a little bit further into this. So a total of 14,000 PSA tests were undertaken amongst patients within the 50 to 69 years, and they were followed by a subsequent test. So overall, 84% of the tests were returned as normal, and the median time interval until the subsequent PSA test was 12.4 months, which is interesting because the recommendation is 2 years. 16% tests had abnormal results, and the median testing interval was 6 months, nearly 6 months. So interesting how there's an example here possibly of over-testing, and there's also an example of possibly under-testing or not carrying forward, not fulfilling the guidelines. Across the PHNs, there was little variation in the distribution of results. PHN2 showed a slightly higher percentage of abnormal results and a longer interval, 6.4 months following an abnormal test. The third one I want to talk about is vitamin D testing in Australia. So in 2013, there was a study by Belinsky and Boyages. They looked at Medicare data and they reported a large increase in vitamin D testing across Australia between the 2000 and 2010. Most vitamin D requests are made by GPs. So their study couldn't determine the reason for ordering of the test, but the increasing availability and accessibility of vitamin D tests are thought to be contributing factors to the increase. Then in 2014, there was a review on vitamin D testing by the Australian Government Department of Health. It was released, and the review said that a majority of the requests originated from GPs, and they were worried that these originated for the purposes of screening, and the conclusions drawn from the report were led to changes in Medicare payments and Medicare items. Then by 2016, another paper by Boyages, after the changes implemented in Medicare, observed a reduction in vitamin D testing, which was decreasing at the time of that publication, 2016. So we want to have a look at what's happened since, and does the data that we have mirror these observations. So what we found was that overall, 12.35% of test requests overall had a vitamin D test. That's over nearly 13 million requests. 10% of males and nearly 14% of females had a vitamin D test. Vitamin D tests mostly occurred in the spring, least occurred in the summer, and pretty much similar proportion occurred in autumn and winter. So when we look at vitamin D testing over the years, you can see the impact of those different landmarks. So the Belinsky-Boyages publication comes out, the MBS review follows it, and there's a dip in vitamin D testing. But what's interesting is that there's also, particularly around 2016, 2017, maybe there's a rise happening. So we investigated a bit further. And we looked at the recommendations on vitamin D testing from the Royal College of Pathologists of Australasia, and they sort of recommend that indications for initial testing of vitamin D should be for osteoporosis, hyperparathyroidism, malabsorption. It's not recommended for routine screening of health populations, including pregnancy. So we're able to examine them. So here is vitamin D testing, where the actual reason for the patient visiting the GP was encounter for checkup. And you can see it's quite clearly, that's where a lot of vitamin D testing has been occurring. Quite clearly, again, the impact of the MBS review and the Belinsky paper is seen, particularly around 2013. And again, we start to see it rise after 2015, 16, 17. Fatigue. So this is not as sharp a sort of, but there's obviously a similar pattern here. It rises up to 2012, it dips, it starts to rise again. Pregnancy, again, which was not recommended by the RCPA, similar pattern. It rises, 2012, it dips, starts to go up again. Then we look at osteoporosis, which is a condition that vitamin D is recommended, and it's fairly stable, and it has a different pattern, which suggests, at least in this case, it's remained fairly constant, as opposed to the others where it has not. So in terms of a summation of the results, I think we could say that vitamin D testing increased up to 2013, after which its use started to decline and plateau. There's evidence of another onset of increased vitamin D testing, some of which may be considered low value, so something that to be considered. It may be worth revisiting vitamin D use to see if the trends have changed. So I've given you 3 examples where pathology testing was used in general practice, and we used it to connect to some consideration of the quality of care, the value of care, and comparisons to best practice guidelines. Electronic health data was key to it, but there are a lot of challenges to use of electronic health data. One of the things that constantly comes up is ownership and transparency. Obviously, who owns it, and its transparency is a big issue. It's sort of been at the center of digital health informatics for a long time. If we are going to talk about putting patient-centered care and bringing in shared decision-making, obviously shared decision-making relies very heavily on being able to give information to patients. So that's a key question for electronic health record data. Traditionally, data in healthcare is being siloed, fragmented, and there's a lack of interconnectedness. Oftentimes, data might exist in 2 different rooms and they're not connected up. So it means that we can't sort of see patterns and relationships that might be very important too. We tend to sort of isolate rather than integrate. A lot of this has got to do with the lack of standardization. In pathology, there's a lot of talk about harmonization so that we can talk to people from different parts of the country. People can visit different GPs, get tests at different places, and feel confident about the results. And there's also public concerns about privacy and data security. So they're the challenges that confront the use of electronic health record data. But here are the advantages. It's longitudinal. So one of the things that I was hoping that came across in this presentation was that we were able to look at things over time. We were able to see changes. We were able to, particularly with the vitamin D example, we were able to say, well, if an intervention or something happened in some year, can we see a change? It's comprehensive, so you're able to make comparisons by socioeconomic status, gender, geography. These comparisons can be powerful because there's a huge sample size. For a researcher who I've been doing research for a number of years, but a lot of research you had to do by carefully going through over years, sometimes carefully going through records and everything. It takes a long time to do that. You might find something, but by the time you found something, things have changed. So, you know, it's not timely, it's not dynamic, it's not meaningful. We're often working retrospectively, we're reacting to things. So electronic health record data allows us to be a lot more dynamic and timing. It's outcome focused, because it can focus on, well, what did it actually do to the patient? How did it improve? Or was there something that didn't happen that should have happened? And we can monitor quality. And that's a key thing here, so that we might see some patterns that might may need consideration of quality improvement, may need to you know, carry out some educational process. I think the primary health networks particularly are very keen to get that sort of overview and to, you know, be able to monitor how care is being developed and provide feedback, which is a really key part of this exercise. The data that I've used from this presentation is part of a report that's available on our website there. It was a report that contains the instances I've used, but a lot more. If you're interested in this area, there's a lot more that you can go through, and it'll probably give you a way of exploring some of the issues that are being raised here. Thank you very much for listening. Feel free to contact me if you'd like, and this is just a plug for the research conference later in December 2021. Thanks very much.
Thanks for that, Andrew. Now, there was some chat going on, which I will share with you if we have time, but there's a couple of questions from participants, which, if I can start with the one from Janet Hiller. She's asked, how did you deal with the changes in Medicare item number structure over the study period?
Sorry?
How did you deal with the changes in Medicare item number structure over the study period? So how, you know, when the Medicare item numbers changed or were rearranged, how did you account for that in your data acquisition?
So in terms of pathology testing, we were actually looking at pathology tests that were undertaken. So we didn't have to account for anything there, because we're really, the only part here in the presentation that I looked at NBS items was the ones that were related to vitamin D. And also, I think I also looked at service implementation funding. So we didn't, we were provided with NBS item numbers, and we're also provided with pathology tests and their line codes. So we're able to compare both of them and to make sure that there was consistency across. And
there was?
Well, yes, we had to make sure there was, because that was important to sort of drawing the analyses. A lot of the data initially was really to make sure that there were valid comparisons that we were able to make. So a lot of what we did earlier on in the study was to actually compare with previous studies, like the Beach study, to see that what we were finding was comparable to what others understood and what others had reported previously.
Right. So it was primarily the data extracted from the general practices, and you just confirmed that against the Medicare data. Is that correct?
We had Medicare data, so that where there was instances where pathology tests might be undertaken, and there was a Medicare item, we did check to see if they were comparable. The thing about pathology testing that we have as an advantage is that pathology testing, we could actually look at all the pathology tests. The problem with Medicare data looking at pathology tests is that they're coned. That means they take the top 5 and they don't tell you all the tests that were undertaken. And because MBS is really, it's a financial thing, we want to look at the raw data. So what pathology tests? So we previously, looking at MBS items for pathology testing was always fraught with problems, because you could not identify all the pathology tests that were there. You got the top 5 because that was what was paid to. So we needed to look deeply, and that was the advantage of having electronic data, is that we could actually identify every test that was undertaken.
Great, thanks for that. And Janet's just let me know that that was a great answer. I'm just going to jump in. There's another question up on the question board from the participants, but I just want to ask you about the, again, about Medicare item numbers and how much that influenced, do you think, the requesting practices of GPs? You know, so I'm thinking along the lines of provider-driven demand.
You're talking about the prostate cancer, or?
That was the vitamin D, the one that increased over the
vitamin D,
years.
okay. Look, I can't really, it's hard to sort of work out why the vitamin D ordering has gone high. We all saw it and there was a lot of news about it. One of the things that we'd like to do is actually address it through discussions with GPs actually. So one of the things that's always good to do is to say, all right, so here is the guideline, here is how different practices are performing, why is this happening and what might be the reasons for it. Now, one of the things that you always have to be very careful about, particularly, you know, when you're talking, giving that feedback, is you actually have to understand that the patient is a factor here. The patient wants a test, you know, so you don't, you know, I really understand that if a patient comes to a GP and the patient says, I want this test done, and the GP says, no, you don't, it's against guidelines. Well, how is that going to help a patient? You know, so it might be understanding that sort of interplay and understanding the issues and understanding patients' concerns is a key part to sort of using this data. So this data, the data that we presented today is not meant to sort of be like a battering stick over GP. It's meant to sort of like raise questions. It's meant to actually address some issues. Maybe one of the factors that we need to consider is how can we provide this evidence to patients as well? Because it's not just an education of general practitioners, it's also something that patients need to know. So they're all the issues involved. And I think that we're still grappling with a lot of them, including the PSA test. I think I showed that a lot of men aged over 70 are having PSA tests. When we asked GPs about this, they said, well, generally they feel like if they haven't got a test, they're not got their money's worth. So, you know, it's a little bit more complex than you either do it or you don't. There's a lot of issues involved, but you need to know what's happening. So you need to know the data so that you can actually start to address them.
Thanks, Andrew. There's a comment from Oliver Frank, just asking about the PSA testing. On your slide was advised by the Cancer Council that in Australia it's done every 2 years on men between 50 and 69, but he can't find that on the Cancer Council website.
So we took that from the NBS review. So you'll have to contact me and I'll have to look that up for him, or we can talk about that. Yeah.
Yeah, no problem at all. Thank you. Just another question is, what's the purpose of standardization in the analyses? The distribution of patients in general practice does not reflect census data, and that adjustment would influence findings coming back to the PHNs.
So in terms of the reason we wanted to sort of look into that is that if we find that there's a lot of, if a population, particularly a PHN, or, you know, in this case, a regional PHN, has a lot of younger people, we wanted to sort of, if we wanted to compare and use benchmarks, we wanted to take it into account what are the different factors. If it's got a younger population, is that influencing the number of tests that are happening, or is it is there other reasons for it? Is the fact that they're regional and they're finding it hard to get across to a GP? I mean, there's a lot of factors. So in order to compare and to set some benchmarks, or to sort of look at trends or what's happening, it's usually a good idea to sort of look at it in context of, well, the reason this PHN might be having more is because it's got a certain level of population. So I think that was the reason for it. It's for really just to be able to compare accurately. Sometimes it's a useful device. Other times you don't need it. You just need to know how many is happening. But we did want to, generally when we were comparing across PHNs or across different sort of factors, we wanted to be able to sort of look at it so that the comparisons were fair.
Thank you. There's two more questions coming in from participants. One is asking how you dealt with duplicated requests of the same exam for the same patient on the same date. So the comment is that in some of the graphs, the number of tests for a particular exam were higher than 100 per 100 visits.
So I'd have to sort of repeat that for me. I understand that there's an issue with repeat tests. If it's we shouldn't have repeat tests that are happened two for the same day. Obviously, if it's so, what happens is that what we did was look at requests, and a request might have different tests, a number of different tests in it. We actually had a definition for what a request is, so that, for instance, if someone had a test or a group of tests, because they never really, if you're going to take some blood, it's not going to be just for one test. You probably have about 3 or 4 or 5. So what we did was that we said, okay, within a certain time period, if all those tests fall within that time period, we count that as a test, right? Not as 5 tests, you know. Now, if it was repeated in the same day, I would assume that that would be a little bit strange. So we probably have to sort of, you know, validate that data. But we did have to actually have some clear definitions of what a test was. Pathology tends to sort of be a little bit complex in that regard. So yes, there was, and I think if you look at the report that we issued, there's some sort of definitions about how we counted tests. It was an important issue that we struggled with for a long time, because it's important to sort of be able to be consistent.
The next question is, how do you envisage using this data in general practice to improve the quality use of pathology?
Okay, so because this was a collaborative effort with the PHNs, what we envisaged was that, and what we've done is actually report back to them. Actually, from there, we wanted to undertake some obviously maybe sort of presentations to general practices, or perhaps if the PHNs felt that there was the need for an intervention, maybe an educational session, or maybe a flyer that goes around. You know, there's many things that you can use, many sort of tools that you can use to influence or sort of affect practice. Some of them might be decision support tools. The MBS review is very keen on building clinical decision support. Now, the point about clinical decision support is that it might be something that that when a GP makes an order, they get some sort of information about that may not be necessary to do this test, or this test is not called for. It might be a prompt. Another area that you might like that could be considered is providing decision support that goes both to the GP and to the patient. So there are areas that you can look at, and the MBS review actually lists a number of them. And I guess the one that I'm most interested in is where we can make it electronic. So it becomes something that sort of relates to the general practitioner, but also relates to the patient, so that it sort of maybe asks some questions, maybe provides some prompts, maybe gives some more information that might be necessary, or prompts some extra action. So yeah, there are a number of areas which can be pursued. We are doing this with the PHNs, and it's actually taken a different meaning now, because it's relating to what's happening with COVID-19, and we're sort of considering work to actually monitor some of these findings and actually take it forward and monitor some of the responses to COVID-19, because there's been a lot of concern about maybe a drop in pathology tests and maybe some tests that should be being done, whereas previously in this work I reported maybe over-testing, we might be now dealing with under-testing. So there are a lot of issues where the PHNs can take this forward.
We have a little bit of time. There's one more question on the Q&A, that's how did you account for changes in guidelines or recommendations for testing over that period? So for example, vitamin D promotion resulted in increased testing, which kind of answers my question. Or is that subject to further investigation once the patterns are established?
So how did we relate to for the changes in guidelines? Is that so?
Yes. Yeah. How did you account for changes in guidelines and recommendations for testing?
So, well, I guess what we wanted to see is, did the change in the guidelines, what impact did it have on pathology testing? That was our first issue. Obviously, you know, there's different changes in guidelines. It might be a national type thing where it's issued as it was in the case of vitamin D. But oftentimes a PHN might offer some advice or issue some, you know, educational or something. So they're things that we can measure. And the idea is that you actually, you know, sort of, you can do it, you can look at it longitudinally. You can say, okay, so when did this happen? So is that what you mean by accounting for it, or?
I think the question based on whether the changes influence the prescribing, the requesting practices.
Yes.
But that's actually what you were looking for, from
Yes,
what I
that's
can
exactly
understand.
right. Yeah.
So, yep. So Andrew, there's quite a bit of chat going on, and we don't have time for all of it. We're almost out of time, but I just wanted to comment on a couple of things that are in the chat. One comment from is that that GPs don't have to provide a reason for tests they request. So, they say, I believe that a large proportion or even a majority of requests made by GPs contain no clinical notes or reason for requesting the tests. So do you have any comment or on that? I mean, from my perspective, working for many years in a pathology lab, I didn't see that very often, but perhaps that's more so in general practice than in public health systems.
Yeah, look, that's a very interesting point, a very good point. We had a lot of trouble with you know, general practice. I worked a lot in hospital situations, researched a lot in hospital situations, and everything is treated like there is a diagnosis, there's an episode, you get a diagnosis, and everything revolves around that. In general practice, it's different. You're talking about, the key issue is the continuity of care. So, so every time a patient comes to see a GP, they might be a diabetic or whatever, but they might not be going in there all the time for diabetes. There might be something completely different. So we actually had to do a lot of reviewing of the data to start to identify which patient and when did they have that diagnosis, and is it relevant. So, and also, whereas in hospitals, it's, you know, there's a sort of requirement, you write down the main diagnosis, or you list the key diagnosis, and then there's the key treatments that followed it, and it's all part of, you know, the case mix and working it out. It's not as clear in general practice because it's, you know, there's a lot more complexity to it, which makes it a bit more difficult. And even, for instance, understanding what the diagnosis was interesting, because a lot of it's just notes, you know, could be, or question marks and things. So they're issues that I think are really up for change. I think they're, you know, I feel that if we can get some data and do some analyses, we can actually start to address improving these and say it would be more useful if these data had this, you know, clear standardization. So in other words, we've got a long way to go with general practice in terms of, you know, getting the data to be more useful. And part of that will be to actually feeding this back to GPs and sort of getting their feedback and actually working out how we can improve it. It's challenging, but I think it's going to be important.
Yes, I agree. So we're just about out of time. There's just one small comment I'll make before I finish off, and that's that somebody commented that they think in New Zealand only specialists can order a vitamin D test because of overuse.
That's interesting.
Are you aware of that?
I'm not aware of what they do in New Zealand. I do know that we looked at a lot of conditions and we sort of wondering, and then we realized, well, specialists mostly do this ordering. So we had to actually, you know, it was a little bit more difficult, and we didn't have, apparently in the data source that we have, we do get specialist orders. So every pathology test gets reported, you know, a lot of them get reported back to the GP. So we were able to account for that, but it's an important issue because a lot of it's, a lot of care that in primary care goes across different boundaries. So it does make it a bit more complicated still. But that's a very important point that we found very challenging for a lot of our analyses.
Okay, so we're pretty well out of time now, Andrew. Thank you very much for that presentation. And as Andrew said, the report is on their website. I'd just like to remind everybody that a recording of this session will be available on the Health Services Research Association's website tomorrow. And I just want to thank you again for that very interesting presentation, Andrew.
And thank you for allowing me to give the presentation. And thank you to the audience with all those really interesting questions. It's like to follow them up if they're welcome to follow up with me.
Great. Thank you very much, Andrew.
Thanks.
Sarah, is there any other last minute comments from you?
No, that's it. I'll get the recording up as quickly as I can. Thanks, Tilly, and thanks, Andrew.
Thank
Thank
you.
you very much.
Bye, everybody.